Welcome to Lunch Learn Link. This is a seminar sponsored by the Sidney Kimmel Comprehensive Cancer Center and the Cigarette Restitution Fund Research Grant at Johns Hopkins. And so once or twice a month, we have seminars about cancer and especially about prevention and control. So today we welcome Corinne Joshu, who's a member of the Department of Epidemiology. I remember when she came. She is a graduate of Washington University, and then she got her doctorate in epidemiology from St. Louis University. So she might be a Midwesterner, I'm not sure. And anyway, she's made a home here in various ways. So the topic today, you'll hear about the connections to the prostate cancer program and a group of investigators that she's working with there. But also in epidemiology, she's working closely on the ARIC study and the CLUE 1 and 2 studies, where there are actually biologic specimens that can be used for cancer investigations. So Corinne might be the person for you to know better, but we welcome her today. Thank you.
Thanks, Norma. Thanks, everybody, for coming. So today I'm going to talk to you about obesity and lethal prostate cancer and some of the work that we've done and others have done in this area, and then also how this might lead us to new opportunities for prevention. So the objectives for today are to describe the association between obesity and prostate cancer, so what we know so far, identify some of the possible mechanisms that underlie associations that we've observed, and then also talk about the clinical relevance of these associations. So this is a study it was published in 2007, so from some time ago, but it really reflects basically what all the major cohort studies were observing, and that is that BMI was associated with a significant inverse association between BMI, increased BMI, and prostate cancer incidence. So this is total prostate cancer incidence. So we had the unusual situation where obesity looked like it was protective against prostate cancer. And that's not what we see for most other cancers. Obesity is generally a risk factor. So as people looked at this more closely and pulled out bad prostate cancer, or in this case, fatal prostate cancer that leads to death, they saw a very different pattern. So you see this pattern where obesity is associated with a decreased risk of total prostate cancer, but an increased risk of prostate cancer that leads to death. Okay, and so this is reflective of many studies around that time. And now if we look at more modern publications, we see a meta-analysis where when they look at sort of the weight of what's been done, you see that obesity is really not associated at all with what we would term as localized disease, so very early disease that's not likely to go on and cause death. But there's a modest but significant association between obesity and advanced prostate cancer. And you see the same pattern for prostate cancer mortality. Okay? So for prostate cancer, the way it's generally detected, you have some sort of, in this country, it's been PSA screening for many years. So your PSA hits some level, and then you go on for biopsy, and they look to see whether or not there's prostate cancer there. So when you restrict to studies among men who actually had the opportunity to go on and have biopsy and actually had the opportunity to see whether or not they had prostate cancer, you see a positive association between elevated BMI and prostate cancer detection. And this starts right around here at 25 or 26, so right when you start getting into the overweight category. So if you, again, restrict this and look at high-grade disease. So among men who everybody had a biopsy, so we were looking for cancer, did we detect high-grade disease specifically? You see that same pattern of association. And again, you see this starting to rise around 24 or 25, so in even the upper levels of what we would consider normal weight. Okay, so one of the things that we've been interested in is whether or not these associations are the same in Black and white men. And the reason for this is that compared with non-Hispanic white men, non-Hispanic Black men have twice the risk of dying of prostate cancer. So when we're identifying risk factors, many of these risk factors that we find have come from cohorts of predominantly white men, and we want to know whether or not we observe those associations in men of other racial and ethnic background. So there have been limited studies of weight and prostate cancer risk by race, and these studies have largely had inconsistent findings, and they've been working with relatively small numbers. So we've been looking in the ARIC study. So many of you may be familiar with this study. This was started in 1987. It's a prospective cohort with 25% Black participants. There are many special things about this study, but in particular, what's special with respect to obesity is that there are repeated, clinically evaluated measures of body size. So we're not relying on self-report, but they're actually in the clinic and they're having these things measured. And now we're up to around 30 years of follow-up. So in this group, we looked at the association between obesity and lethal prostate cancer. And so when I say lethal prostate cancer, I'm talking about a prostate cancer that at the time of diagnosis was already bad, or a prostate cancer that led to death in the future. And so we see in our overall group that obesity is associated with an increased risk of lethal prostate cancer. And certainly we see that pattern for white men. For our African American participants, we see a similar positive association for obesity, but it didn't reach statistical significance. But in general, the inferences were similar. And I should point out that in this study, because these participants are so well characterized, we're able to adjust for factors like updated cigarette smoking, which is a risk factor for fatal disease, and other sort of markers like insulin and glucose. All right, so this is a figure from the World Cancer Research Fund. So for those of you who aren't aware, this is a group that periodically produces a big report that tells you about all kinds of nutritional factors, obesity, physical activity, and the association with all kinds of different cancers. So anything you might be interested in, this is sort of the Bible. And they continuously update that. And so when you look at the entirety of the world's literature, they come to the conclusion that body fatness is a probable risk factor for advanced prostate cancer. And so generally the consensus is that obesity is a risk factor for advanced, high-grade, or fatal disease. So what about weight gain? So obesity is bad. That's kind of a consensus for this disease and many others, but what about adult weight gain? So there's been a lot of interest in not just being obese, but the change in weight that people experience over time. So there have been relatively few studies that have been able to look at this, but among those that have, when we look at total prostate cancer, this is weight gain along the bottom of these figures. So total prostate cancer, we see a positive association between weight gain and total disease, but this is mostly driven by high-risk prostate cancer. We see that same for lower intermediate risk prostate cancer, where it becomes a similar association that we saw between obesity and total disease. When we look at fatal prostate cancer, the axis changes here, and you see upwards of an over twofold increased risk at the outer categories of weight gain. So adult weight gain, adjusting for where you start, also appears to be a risk factor for bad disease. What about in ARIC? So in ARIC, we looked at an annual 2-pound increased weight gain over the course of 12 years around midlife. And again, adjusting for where men start. When we look overall in the light blue, we see a suggestive positive association between annual weight gain and lethal prostate cancer. But that association looks like it's stronger among men who were overweight or obese at the start. Okay, so it seems to have more of an impact there. When we looked separately by race, once again, we see that the association appears to be more pronounced for white men as opposed to African American men. But again, remember, we have fewer participants in that group. Okay? And I should also note that these associations were close to statistically significant, but they didn't reach statistical significance. All right, so does the extent of body fatness and or weight change influence the risk of prostate cancer recurrence or death in men with prostate cancer? So far we've been talking mainly about a cohort of people who start without any disease. We follow them forward in time for bad outcome. So what about for guys who already have the disease? Is there any impact of weight around the time of diagnosis or changing weight on their outcomes? So this is a meta-analysis of studies that have looked at BMI around the time of diagnosis and what we call biochemical recurrence. So biochemical recurrence, I'll talk about a little bit more later, but this is essentially where you have a man who's diagnosed with prostate cancer, they were treated, expect them to be fine, but they start having detectable levels of PSA, okay? And so sometimes this goes on to progress to detectable metastases and death, and sometimes not. But we do see that increased BMI around the time of diagnosis is associated with an increased risk of biochemical recurrence. This is a meta-analysis looking at BMI around the time of diagnosis again, and post-diagnosis survival, here in the bottom in red. And again, we see the same sort of pattern. If you're obese around the time of diagnosis, you have an increased risk of dying of the disease. So this is a study that we conducted now many years ago in men who were surgically treated for prostate cancer across the street at the hospital. So this has fueled a lot of our interest kind of in this topic, where we were looking at weight change around the time of diagnosis and risk of recurrence. So what you can see here is, again, adjusting for where men start, that there's a significantly increased risk of biochemical recurrence in men who were gaining weight around the time of diagnosis as compared to men who had stable weight. And so what's probably most interesting about this figure are these people down here. The people who were losing weight appeared to have a lower risk, right? So anytime you see maybe lower risk, we think opportunity to do something. Now, the problem with weight loss in observational studies is, one, in the middle of an obesity epidemic, it doesn't happen that often, right? So we don't have a lot of numbers in those categories. And two, we don't know why people are losing weight. So are they losing weight because they're sick, because they have some sort of problem, or are they losing weight because they want to, right? It's intentional weight loss that we're interested in, but that's not something that we have captured well in our cohorts thus far. So here's another study where they were able to look at weight change since the age of 21. So for people who are further away from 21, as opposed to closer, you can imagine that it's not that hard to accumulate some weight. And so when you look at men who had stable weight compared to men who gained weight, so men who were gaining weight, again, these are all men who were diagnosed with prostate cancer that we don't expect would be bad or lead to death, and men who had gained more weight since age 21 had an increased risk of going on to develop lethal disease. We have this weight loss here at the bottom in the light blue, possibly lower, but they didn't have many men in this category. Okay, so anytime we're talking about obesity and prostate cancer, we have to think a little bit about whether or not this is cause or if this is bias. So obesity may be causally associated with poor prostate cancer outcomes. We see an increased risk of lethal prostate cancer, increased risk of recurrence, increased risk of death among men with prostate cancer, and a decreased risk of non-aggressive prostate cancer. Okay, so we've observed that in many studies. But we also have to think about detection bias. And mainly this is because of reduced levels of PSA in men who are obese and an increased prostate volume. So if we think about that a little more carefully, we know that there's a differential opportunity to receive PSA screening based on weight. So higher SES men are more likely to be screened and less likely to be obese. So it may be that for total prostate cancer, this inverse association we're seeing is because we're not getting obese men in and screened in the same way that we are normal weight men. So that's one possibility. There also could be differential detection of the presence of disease just due to obesity changing your PSA level. So obese men have lower testosterone levels, and PSA is under androgenic control. So you're producing less PSA, then you're less likely to meet that cut point to go in for biopsy. And there's also an issue of hemodilution. So if you take a normal weight man and an obese man, and they're putting out the same amount of PSA, an obese man has a higher blood volume and therefore a lower concentration of PSA, right? So they have to put out more PSA to make it to that detection level. And then when they do actually reach the point of biopsy, obese men have larger prostates compared to normal weight men. So if you're doing a standard biopsy for the same tumor size, same number of cores taken, detection is less likely for an obese man. Okay, so we might be not detecting the disease as well in obese men as compared to normal weight men. So that could, one, account for maybe the lower risk of total disease and or account in part for the fact that when we actually detect the disease in obese men, it's more likely to be worse, right? Because it took more for them to get in there and have their disease detected. But there could also be causal linkages. And so now I'll switch a little bit and start talking about some biological mechanisms that might explain some of these associations. And so there's some evidence that there might be some etiologic heterogeneity in prostate cancer. So TMPRSS-ERG is a common gene fusion. So this is very common. We see it in lots of cancers. Around half of European American men, possibly less in African American men, have been reported. And so when ERG binds to TMPRSS2, which is a gene that's under androgen regulation, you effectively have an oncogene that's under androgen regulation as well. Okay? The thing about this is that the fusion doesn't appear to be prognostic by itself. So there's no association between having this fusion and anything that happens with your outcome. But it's possible that it modifies the influence of obesity on progression. So this is baseline obesity. These are men from the health professionals follow-up study. And what they looked at here is starting from baseline, a cohort of people who did not have prostate cancer. And they followed them forward and asked whether or not they developed any prostate cancer, but in particular, whether or not they developed ERG positive or ERG negative cancer. What they see is the same pattern that we see overall, where you see a suggestive inverse association between obesity and total disease. But this was significant for ERG positive disease. So obese men were less likely to develop an ERG positive tumor. And they really saw no association for the ERG negative outcome. So there's evidence that androgen signaling promotes this fusion. Okay, so this is based on exposing prostate cancer cells and immortalized non-malignant cells to dihydrotestosterone. This might promote the fusion, some studies. And in the same cohort, they previously observed that increasing circulating free testosterone had a suggestive positive association with ERG positive tumors only. And so the hypothesis here is that obesity leads to lower testosterone, which we know, but then also leads to a decreased risk of developing ERG positive tumors. So that's one causal mechanism by which you might see a lower association between obesity and prostate cancer incidence. But what about among men with the disease, already diagnosed with the disease? So does ERG modify that association? And so this is in that same cohort where they looked at the association between obesity and lethal disease. So these are all men who have the disease. And they looked at obesity and whether or not it was associated with going on to develop lethal disease. But they stratified by whether or not the men had ERG positive or ERG negative tumors. And so when they looked overall, they really saw no association. But most of what they observed was that obesity was associated with lethal disease, but only in the context of an ERG positive tumor. They really saw nothing for ERG negative. If anything, the pattern seemed to go in the other direction. So when we look more closely at this, we know that ERG positive tumors have higher insulin receptor expression. They also have IGF-1 receptor expression. And the hypothesis here is that obesity increases your amounts of insulin and free IGF-1, and that leads to an increased risk of lethal disease. And so, again, this is based on one study, a very good study, but the data in this area is limited, but suggests that obese men may be less likely to develop an ERG-positive tumor, right? You might be at a lower risk of actually developing that type of tumor. But once you have an ERG-positive tumor, then growth-stimulating hormone levels might promote lethal progression. Okay. All right, so what about the prevalence of PTEN loss? So PTEN loss has been consistently associated with lots of bad things in prostate cancer. So this is a tumor suppressor gene that when you lose it by mutation or deletion, it's pretty common. In prostate cancer, relatively common. And it's been associated with all kinds of bad things. So if you have PTEN loss in your tumor, you have an increased likelihood of having extra prostatic extension when you've in surgically treated men. We have an increased risk of recurrence after being surgically treated. And it's also been shown to be an independent prognostic indicator of dying of your disease. Okay, so PTEN loss is bad. And the question we had was about PTEN loss and BMI. And we know that PTEN loss is in general more common among ERG-positive tumors. They tend to travel together. And there's some limited evidence that PTEN loss might be more associated with lethal disease if you have an ERG-negative tumor. So we looked at men who were surgically treated across the street, and we asked whether or not your pre-diagnostic obesity level was associated with the prevalence of having PTEN loss, and whether or not if you were changing weight around the time of diagnosis, there was any association there. And what we saw were that overweight and obese men were more likely to have PTEN loss in their tumor at the time of surgery. And we really saw no association for weight change. But certainly, overweight and obese men had a greater than twofold risk of having PTEN loss. When we looked by ERG-negative, ERG-positive status, because we know these things travel together, we saw this was certainly the case for ERG-positive tumors, though we observed a similar pattern for ERG-negative tumors, though not statistically significant. For weight change, nothing was statistically significant. There appeared to be a little bit of a dose response going on for ERG-negative, but again, nothing reached statistical significance. But again, suggesting that obese men were more likely to have PTEN loss in their tumors. Okay, so what about other biological mechanisms that might contribute to the obesity prostate cancer association? So I'll talk about three. I'll talk about telomere shortening, inflammation, and then some metabolic perturbations. Okay, so telomere shortening has been is a possible mechanism that might underlie this association that we've been observing. We know that shorter telomeres in prostate cancer-associated stromal cells are associated with bad outcomes for prostate cancer, including biochemical recurrence, metastases, and death. And this is particularly true if men have short telomeres in their prostate cancer-associated stromal cells and a lot of variability in their actual cancer cells. And so there's also evidence that telomeres in circulating white blood cells are shorter in people who gain weight or people who are obese. And so we were wondering whether or not obesity influenced telomere length actually in the prostate. So not in circulation, but in the target organ. And there's never, at this time, there hadn't been a study that had evaluated prostate tissue-specific telomere length and measures of adiposity or activity at all. So we're looking for a direct mechanism for how obesity might actually influence something in the prostate. And so when we looked at this, what we saw were that men who were overweight and obese had shorter telomeres in their prostate cancer-associated stromal cells. And we also saw that men who were very active had longer telomeres. So more active men, they had longer telomeres. Overweight and obese men had shorter telomeres. And then when we looked at the combination of this, we saw that obese men who were very inactive had almost 21% shorter telomeres in their prostate cancer-associated stromal cells than normal weight men. And even when we restricted to obese men, we still saw that obese men who were inactive had shorter telomeres than obese men who were active. Okay, so for us, this was very exciting because we're linking obesity to actually something changing or something present in our target organ. And so more recently, we've looked here at men who've been surgically treated at Hopkins. And what we see is that among men who have aggressive disease, they were 3 times as likely to have short telomeres in their stromal cells as compared to normal weight men. So obesity was associated when we repeated the study with shorter telomeres, but for us, or in this study, it was confined to men with aggressive disease. Okay. So what about inflammation? This is a common mechanism that people are interested in when you think about obesity. Obesity is associated with higher levels of systemic inflammation. This is often captured by C-reactive protein. It's also increased risk of inflammation actually in your prostate is also associated with a higher risk of high-grade prostate cancer. And so our question was, well, is obesity associated with a higher prevalence of inflammation in the prostate? Can we make the link that way? And so this is data from a study that Elizabeth Platts led. And so this is where they looked at men who were participants in the prostate cancer prevention trial. So what's unique about this study, so when you're talking about studies of prostate cancer and you want to do tissue-based studies, you really only get to look at people who have had their tissue removed. It's not something that people volunteer to have prostate biopsies in general. And so usually men already have an indication for biopsy. What's unique about this trial is that men were followed for 7 years, and at the end, some men agreed to have a biopsy with no indication. So you actually had the opportunity to look at tissue in men who had no indication for biopsy. So it's a very unique study in that way. And so in this study, they looked in the placebo arm, they assessed inflammation in these biopsies, and they asked whether or not inflammation was associated with prostate cancer. In the trial, they saw, yes, it was overall, but it was particularly associated with high-grade disease, so worse disease. So we went to the same study, and we asked whether or not obesity was associated with inflammation in men in the controls, and whether or not we saw any sort of association between obesity and inflammation, right? And we saw nothing. So there was no association between a man being obese and us being able to detect inflammation in prostate biopsy. So this wasn't entirely surprising to us because we kind of seen a similar thing for colorectal cancer. So obesity is positively associated with CRP level, which I mentioned before, and both CRP and obesity have been associated with colorectal cancer. And this is a study from people who were undergoing colonoscopy, again, across the street. And when we looked at tertiles of CRP by body mass index, we see that people who were obese were much more likely to be in the highest tertile of CRP. So we observed that in this study, like many, many other studies have observed. But when we looked to see whether or not CRP was associated with colonic inflammation, we saw no association. So there was no association between your CRP level and whether or not there was inflammation detected in biopsy of the colon. And just like for the prostate, obesity didn't appear to be associated with colonic inflammation. Okay, so we looked at obesity levels and whether or not those were associated with inflammation being detected in these biopsies, we saw no association. So it's not to say that obesity is not working through an inflammation pathway, but we haven't been able to find evidence for it in these 2 studies. Again, these studies are hard to conduct because you have to have normal people who are giving you tissue samples, and those are somewhat hard to come by. All right, so what about metabolic perturbations? So obesity can lead to metabolic perturbations, including hyperinsulinemia, hyperglycemia, ultimately diabetes. So disruptions in the metabolic profile can also change with how long you've been obese, right? So these aren't static. So before the development of obesity, you might be before the development, of diabetes, somebody who's obese might be hyperinsulinemic, but have relatively normal glucose levels. And then later on, as you progress through, you might have relatively low insulin levels and become hyperglycemic, right? So this is changing. And the reason that matters for us is that capturing that point in the natural history of diabetes that's most relevant to prostate cancer risk is really challenging. We tend to be looking at people at one point in time. So this is work that was led by Michael Moroney. So he finished his doctorate here and is now a postdoc. And so we were interested in looking at hyperglycemia and prostate cancer. Okay, so diabetes is associated with lower prostate cancer incidence. That's been observed in many studies. But findings for hyperglycemia have been really inconsistent, and there's very little known about this association with prostate cancer mortality. So differences in the measurement of glycemia, so what biomarker you're using, whether or not participants are fasting, the selection of your reference group, and the handling of people who actually have diagnosed or undiagnosed diabetes is really quite different across studies. Okay? So Michael looked at this in the ARIC study. So again, I said ARIC's got lots of great features, and one of those is that glycemia has been measured with many different biomarkers. And so when he looks at 3 different biomarkers of glycemia, he sees that there's an association between increased levels of fasting glucose and fatal prostate cancer, but there's really no comparable pattern when he uses other biomarkers. And so when he investigated this more closely, he looked at the overlap of the biomarkers, so how people were classified. And he saw that while there was some overlap between people who were classified as normal on all 3 biomarkers, it wasn't 100%. And the same thing for being classified as high. And so I should state that this is not to say that these biomarkers aren't good for diabetes detection and looking at people who are high risk, because in that scenario, you have people who are coming in a clinic setting, they're being measured, they're being evaluated. If they appear high, you might suggest some lifestyle changes or have some other sort of suggestions, but they're being monitored and used repeatedly. And so it works very well for detection of that disease. But what we're trying to do is to capture one moment in time and ask, compared to people who are truly normal, by all indication normal, what's their risk of fatal disease compared to somebody who's truly high? We suspect to be truly high in this moment in midlife, right? So it's a question of etiology, and it's a little different than trying to use it clinically. So what Michael did was look at the combination of these markers. And so he classified people as normal on all of the biomarkers. That was the reference group, so normal by any sort of definition. And then he looked at whether or not you were high on one or more markers. And he also classified people who had diabetes with a diagnosis of diabetes in a separate category. Okay? And what he sees is really anything outside of normal was associated with an increased risk of fatal disease. But in particular, he saw that if you're high on one or more of these biomarkers, you had a significantly increased risk of dying of prostate cancer. So this low category, we've seen that low levels, in particular low A1C, has been associated with mortality of many causes. I should say that Michael looked at this data pretty much every which way, combining undiagnosed and diagnosed diabetes. He tried to adjust for access to care. He did a number of different analyses and combinations, and we came up with the same inference every time. Okay, so here's what I've told you so far. There's evidence that's mostly consistent that obesity is a risk factor for more aggressive prostate cancer, so high grade, advanced stage at diagnosis. There's more work needed in diverse study populations because a lot of this data comes from predominantly white men. There's evidence that indicates that obesity and weight gain are risk factors for poor outcomes in people who actually have the diagnosis of prostate cancer. And again, observational data on adults who are experiencing weight loss is really lacking. And then how obesity and weight gain influences prostate cancer risk and progression is really an active area of investigation. So I've touched on some of the things that we've looked at in terms of etiologic heterogeneity, different kinds of mechanisms that maybe links obesity to these outcomes. And there's many other investigations going on. Right now, a lot of people are looking at the role of periprostatic fat and changes in the microbiome and how those might be prognostic. But if you're like me have public health mind. Maybe it's just that point in your career. You kind of say like, so what, right? Obesity's bad. Hopefully I've convinced you of that. It's bad for lots of things. So the question is really, can we use this information to change outcomes in men with prostate cancer, right? So we're in the business of improving health, not just identifying risk factors. And so that's really where we wanted to go for the next step of this. So 70% of men with prostate cancer are overweight or obese. So they're just like the rest of the country. And this is despite guidelines from the American Cancer Society, our survivorship guidelines that say you should have a healthy weight. So we tell people to have a healthy weight, but just like in the rest of the country and men with prostate cancer, just telling people doesn't seem to do enough. There's been lots of evidence that have shown that weight loss interventions work just as well in people without cancer as people who are cancer survivors. So we know that weight loss interventions can work in this group. And so we wanted to take kind of this information and think specifically about men with biochemical recurrence. So I mentioned them earlier. So there's over 500,000 men in the US who have biochemical recurrence. So these are men who've been treated for their disease and they have no evidence of any sort of metastatic disease, yet they have PSA that's detectable in their system. So because this group is a real mixed bag, there's not a standard treatment. So among these men, you have 500,000 men, they have detectable PSA, they're generally just sort of followed and monitored. So if their PSA is rising really fast, then that's a bad sign. And they tend to end up having clinically detected mets at some point, and they progress on to treatment. Other men are just followed for a really long time and just monitored, and they have PSA in their system, but we don't know why. We have no reason that they might have that. And so men who go on and have those overt disease or overt metastases that we can detect are put often on androgen deprivation therapy. And so this is a really nasty drug. It has really bad side effects. They gain a lot of weight, they become diabetic, they have all kinds of other unpleasant side effects that go along with this. Here at Hopkins, you don't go on that unless you have overt metastatic disease, and that's because going on it earlier has not been shown to improve survival. In other places in the country, men will go on this earlier. So even men who here we wouldn't treat do get ADT in other places. There have been limited studies that have suggested that some of this is due to something that has been called PSA anxiety. So you were treated for your cancer, you should be fine, but you have PSA. Where's it coming from? We don't know. But we're just gonna keep following you and we're not gonna do anything. And that bothers some people a lot. That's a stressful situation. And so there's some suggestion that that might lead to overtreatment with this drug. Okay, so because this is also a mixed bag, there's not a lot of drug development in this space because it's hard to target such a mixed group of men. So we're interested in whether or not weight loss could be a treatment for these men. So could that be something we could do for them? Like I said, treatment strategies for these men, there's not many. And if we can inhibit prostate cancer progression, so inhibit your need to go on to this nasty drug, seems like that would be a benefit. And it also has the potential benefit of working for the whole spectrum of men. So both the men who are about to go on ADT, but also the men who are not. So those men who are just kind of like chugging along, getting monitored, can we make them healthier overall? Can we give them something that allows them to be more active, maybe reduce their anxiety, and benefit them in some way? And so, particularly for these guys where their PSA is increasing very quickly, so they have what we would call a fast PSA doubling time. If we can slow down the need for ADT, that would be a benefit. But also for the entire group of men, we suspect that this might be beneficial for a lot of outcomes that are important to men who are living with the disease, including anxiety. So there have been weight loss trials in men with prostate cancer, but nobody's really measured the influence of weight loss on clinical outcomes in these men. So we know weight loss is good for lots of things, but we want to know whether or not it actually impacts an outcome that matters with respect to prostate cancer, and that is progression of the disease. So this is Jessica Yeh and Larry Appel. Larry Appel was a primary investigator in the POWER trial. So this is from several years ago. This is where they had an intervention where they compared to no intervention people who received their intervention remotely, so on the phone, through the internet with coaches, or people who actually had some sort of in-person contact. And they saw that both of the interventions worked just as well. So important, they lost weight, so this is at 6 months, but they maintained it through 24 months. Okay, so that's what we want. We don't just want you to lose weight, you can get people to lose weight, but maintaining that weight loss is also important. And what's important about this intervention is that they're showing that remote support worked just as well. So that allows us to disseminate it more broadly and reach more people. We don't need you to come into a facility. We don't need you to talk to us in person, but we can reach you through your phone, through your email, and other ways. So with them, we've developed the EMPOWER trial. And so this is a phase 2, 2-arm, single-site, randomized controlled trial to test the efficacy of weight loss as a first-line therapy in overweight and obese men with evidence of biochemical recurrence following local treatment. Okay, so we're going to recruit 130 men. We'll randomize them to receive EMPOWER, which is a 24-month lifestyle intervention based on the POWER trial or standard of care. And what we're interested in is whether or not weight loss reduces prostate cancer progression at 12 months. So we're also interested in biomarkers of insulin resistance and sex steroid hormones. We want to understand more about that mechanism. So we want to look in the men who are in standard of care and see how those biomarkers are associated with progressing on to metastases. And then we also want to know whether or not changing these biomarkers has an impact on whether or not on prostate cancer progression. So here's our follow-up. Everything, our primary outcome, again, is at 12 months. So these guys will come in. They'll fill out lots of questionnaire data, give us biomarker data. We'll look at them at baseline, 6 months and 12 months, and then they'll be followed again at 24 months. And so these are these visits for our trial will run alongside their clinic visits with their physician across the street. So the delivery and the goals of this intervention, this is going to be delivered by the community-based participant engagement and translation developing core over at the Cancer Center. So this is led by Jessica and Larry. And so they facilitate community-based trials at the Cancer Center. So all of our contacts are going to occur by phone and email. There's no in-person visits, so that's nice for us. We can reach people broadly. So we're still working on the protocol. We're updating the POWER trial and adding a piece on prostate cancer. And the goal of the intervention is to have men lose 5% or more of their initial weight within the first 6 months, and then maintain those improvements at 12 and 24 months. So this is largely occurs by meeting dietary and physical activity goals. Most of this is probably going to be driven by changes in diet. And a lot of this functions through accountability. So you're more likely to stay and maintain changes when you have somebody calling you, when you're recording your weight, when you're writing down what you do, and it works pretty well for losing weight. Okay, so this is too small to read, but just to show you that there's a lot of coach contacts, there's different groups or goals that we set with the participants around physical activity, what they're eating, and self-monitoring. So at each of our visits, we're going to go ahead and measure everything to try to determine at some point whether or not their weight loss is mainly facilitated by changes in physical activity or diet. And so that will happen with each of our visits. And then we'll look at many secondary outcomes. And so a lot of these are around your PSA doubling time and your changes in PSA over this time, whether we have any association with clinical progression, and whether or not you actually have detectable metastases. We also are collaborating. There's a group funded by the Prostate Cancer Foundation across the street, where we're establishing a microbiome repository among men with prostate cancer. And so these men will also hopefully contribute swabs for future microbiome analysis. And then we'll collect a lot of different biomarker data and health-related patient-reported outcomes. And I should say that most of these outcomes were selected in collaboration with our medical oncologists, colleagues who talk to us extensively about the things that matter to the men that they see in their office that they're treating. So you're gonna have to stay tuned. We're gonna test the association between weight loss and clinically significant outcomes and progression to metastases. We have a treatment that we believe is without significant side effects, and it can be disseminated widely. This is a remote intervention. And we also hope that this trial will inform the biological mechanisms underlying obesity and prostate cancer. Our goal is to refine this intervention to target the pathways that are most relevant and potentially identify metabolic or hormonal biomarkers with prognostic or therapeutic potential. Okay, so that's what I have for you today. And these are just the many people who've contributed to everything that I've shown you, including our funding, for which we're very grateful. And with that, I am happy to take any questions. Yes, Michael.
So in your very nice talk, I learned a lot about this. That was a very nice talk, and I learned quite a bit about obesity that I should have known. But my question is, in your Empowered trial, you're focused on metabolic biomarkers and hormones, but in some of the lead up to the discussion, you're talking about inflammation, and I was wondering if you had thought about including inflammatory markers or why.
Yeah.
How you walk through that process.
Yeah, it's a good question, and we did initially think about collecting biomarkers of inflammation. What we'll probably do is bank samples. What we would really also, though, want is to be able to link some of that to tissue. But these are men who, in large part, will not have prostates anymore. And the men that come to Hopkins for treatment were not necessarily initially treated here. So even if they had surgery, tracking down their prostate is difficult to do. So for that reason, we didn't fully go that direction, but we do plan on banking samples so we can look at some of that with hopefully future funding.
Yeah, I was wondering whether there had been other studies with weight loss studies for other cancers. In other words, I'm thinking about this, and wouldn't you expect all cancers,
For it to be better?
all recurrence cancers to improve with weight loss?
I don't know. I don't know if it matters at that point. It depends on what you're looking at. So a lot of the studies that have looked at weight loss in cancer survivors have looked at things around quality of life and other sorts of, reduced side effects from treatment. So a lot of the studies for prostate cancer in particular take place around the time of ADT initiation because you gain a lot of weight with that drug. But we don't know actually whether or not it impacts clinical outcomes. Does it make you better overall? Yeah, probably. But does it matter for your disease course? That has not been really well studied. I mean, most of these trials, that's hard too, right? Because what's the timing? That's why we're working in the space of biochemical recurrence, because for some of these, like breast cancer, you might not have an outcome for a long time. Your recurrence, you could go a very long time. So where do you time your 5-year trial, right? What's the right time to lose weight? And that's hard even for prostate cancer. It's just that for prostate cancer, we have this intermediate time period where we might be able to look. So I do think it's probably beneficial in a lot of different ways, but whether or not it relates to clinical outcomes, I don't think is very well studied. But there's a lot of reasons that it's not well studied. It's hard to study. Yeah, or either way. Sorry.
Thank you for the talk. So it's just a philosophical question
Sure.
from a causal inference. So if A is the hidden cause that actually associated with the bad prognosis, and obesity is just the marker, it's not the cause, it's just the marker. And then you are doing intervention to reduce the marker, and then you are looking at the reduction of the marker through another marker. What is the relationship of that marker to A? Because A is the thing that we want to discover.
I fully confess that I'm not totally following. So you're saying obesity is a surrogate for something else.
Yes.
I'm changing obesity.
Yes. And we are measuring the impact of changing obesity on markers that we already measure and we know about. but none of them will tease out A, which is the hidden cause.
What's the actual cause?
Yes.
You're right. So can I tell you what the actual cause is going to be from this study? Probably not. But I hope to be able to inform trials that could narrow it down to start targeting what we think might be the actual causal mechanism. The other thing that we're going to do is have people reduce obesity, which is good for lots of other things. And a good proportion of these men are going to die of heart disease. And so we hope to impact that too. So you're right. It probably won't tell us exactly what the cause is, certainly not in this small study, but it hopefully will put us closer to starting to narrow down some of the biomarkers that maybe we should be thinking about. But it's a fair point.
And just clarification, because I heard that the tool that they use for the power trial is no longer available. A healthy way or something like this. So is there an alternative tool
Yeah.
that you will use for the Empower?
So the tool, by tool you mean there is an online interface
Yes.
between participants and coaches so that everybody can see the same thing. We're not going to be using the same thing that they use for the power trial, but we will be using a different online interface. Yep. Yep. Hey, Richie.
I didn't see, are you planning on randomizing everybody to weight loss even if they're not overweight?
Oh, no, so I'm sorry. That's a good point. We're only recruiting men who are overweight or obese, and then they'll be randomized to standard of care or the Empower intervention.
Also, from the initial data that you gave, it seems to me 130 is pretty small in order to get the effect.
Yep.
Will the intervention, will what we know about that intervention and how much weight loss, is that adequate power for your size?
That's a good question. And we did a simulation study of men who were treated by prostatectomy at our institution in order to get the prevalence of progression among men to power it. And so we're powered to detect a 30% difference between the intervention and the control group. That's comparable to what you see for like the impact of an ADT drug. So we do expect to have the power to detect a difference that's still a relatively big difference, but a difference that you see with other kinds of drug options. But it is small. We're limited by not as much money as we'd like.
Is it enough power to show what you expect for a 5% weight difference?
Yeah, I mean, well, it's enough power to detect what we expect, what we hypothesize will happen. I don't know. Stay tuned. It's a good question.
Is the histopathology and the aggressiveness of the cancer part of the stratification?
The question is the characteristics at diagnosis, will those be part of
Yes.
the characterization?
Like the
So-
prognostic index for the cancer itself.
Yeah, so we will have that information and we'll deal with that in the analysis. What's going to be a bigger factor for the randomization is about where they're at in space of PSA doubling time. So that's going to be a restricted level, which we're still working with our colleagues to kind of define. And the reason that matters is that, like I said, some of these men are never going to progress. So we don't really want to test it there because nothing's going to happen. Some of these men are definitely going to progress. And so it's unlikely that weight change is going to do anything to change their trajectory. What we want is that middle space. And so men will be stratified within levels of how fast their PSA is doubling. Question.
So Corey, I know this is not part of your study, but in the big public health picture, is there advice about preventing prostate cancer from all that you know here? Maybe it's to have a normal weight from age 21 forward.
Yeah, I mean, I think the message for prostate cancer, like for many other things, particularly fatal disease, is to avoid obesity, avoid adult weight gain, don't smoke. Current smoking is a big risk factor. So all the things that we say for lots of other things is a benefit for fatal prostate cancer as well.
Hi, I'm not a scientist or anything,
No.
but when I go to the doctor, and I don't have a prostate either, but when I go to the doctors, they talk about BMI. Are we talking about, obesity on the BMI scale that you get from the doctor? Or are we talking about just a couple of, extra pounds for men, around the midsection?
Yeah.
Or because I'm considered obese according to my doctor.
Right. No, it's a really good question. Unfortunately, we're talking about all of it. So it all looks like it's not that great. Even among normal weight men who are gaining a few pounds, it's totally unfortunate. It's not a popular message, and it's hard to maintain, but all of it looks not great for bad disease.
Well, I appreciate all of you coming, especially with the disruptions of the day. We do have pizza today, and it's in the gallery, so you go out of here and go down the stairs, make your way to the big wall, and there'll be some pizza there. And of course, that'll be good for your prostate.
Thanks, Dora.
Thank you.